Hi, I'm Garnet Gilmore, the Director of Marketing and Sales for Warwick Forest. Today, I'm coming to you filming from the Bistro here at Warwick Forest, and behind me is our billiards room where our neighbors can enjoy a game of pool or shuffleboard. We hope you enjoy today's lecture. Your speaker today is Dr. Torres-Medina. Dr. Torres-Medina earned his medical degree in 2013 from the Ponce School of Medicine in Puerto Rico. He subsequently completed a 5-year integrated residency in vascular surgery with Allegheny Health Network in Pittsburgh, Pennsylvania. Enjoying the complexity and variety of vascular surgery, Dr. Torres-Medina has special expertise in peripheral arterial disease with a focus on minimally invasive intervention, as well as endovascular aortic repair and complex hemodialysis access creation and management. Dr. Torres-Medina's mission is to serve his patients with dignity and the respect they deserve. He is dedicated to doing whatever it takes to treat each person, no matter how difficult or lengthy the process is. Dr. Torres-Medina is originally from a small, beautiful beach town in Puerto Rico. Today, he loves the waters of Hampton Roads, along with its people. Outside of work, Dr. Torres-Medina enjoys fishing, running, surfing, and traveling. We hope you enjoy today's lecture.
Okay.
Hi, I'm Dr. Torres-Medina. I'm one of the vascular surgeons here at Riverside, Newport News. I'm going to talk a little bit basic about what vascular surgeons do, and specifically about peripheral arterial disease. It's a kind of like misunderstood specialty, and it's kind of hard to figure out what actually we do. So we have here 4 vascular surgeons full-time here. Okay, so first of all, you guys should think about any questions that you have. I'll answer all the questions at the end of the presentation. But first, I want to start about what do we do. Basically, we're the plumbers of the human body, and then what we do is specialize in all the blood vessels. So we treat all the blood vessels except when it gets into the brain, and specifically the heart. We don't treat anything in the heart. That's a cardiovascular surgeon. But we treat every vessel as soon as they come off the heart, except the arteries that go to the heart, and then all the way to the legs, and then all the way to the neck. But what we do is basically plumbing, opening arteries, closing others, etc. This is basically what we treat. We treat all the veins and all the arteries, again, except the brain and the heart. And there's a lot of diseases that we treat all over the body. But the one that I'm discussing today is a peripheral arterial disease where there's hardening on the arteries. There's 2 main things that happen to arteries, which are the most important and are the ones that cause stroke, they cause heart attacks, they cause aneurysms, they cause people to lose their limbs. One of them is when arteries get hardened, and it happens where they get smaller and smaller, and this happens because of diabetes, high blood pressure, smoking, all these things. And then the other thing that can happen is when you can get aneurysms where the artery becomes big and big, and then that what happens usually it can rupture at some point and result in death. The other thing vascular surgeons do is also work with patients who are on hemodialysis, where we connect the vein and the artery, and they can use that to replace what the kidney used to do. And we treat all of those all over the body. We treat carotid artery disease, which is in the neck, where it can cause one of the #1 causes of stroke in patients. And then any other pathology that involves arteries in the neck or in the chest, except if it goes into the heart. Okay, and this is where I'm going to focus today. I'm going to focus on peripheral arterial disease. And the reason why I picked peripheral arterial disease is because, unfortunately, still with all the technology, all the information that there is out there, every week, my group does multiple amputations on patients because they either never seek medical therapy or they were too delayed, or there's so many things that could happen. And patients, when they come to us, sometimes it's too late to do anything. So I think it's important to educate the patients before any of these bad things happen. There's also issues where it can happen acutely, meaning like suddenly, and sometimes it has to do with when you have atrial fibrillation. You can have other things, but specifically today we're going to talk about narrowing of the arteries that's chronic, not something that happens sudden. Full screen. How do I make this full screen? They're asking.
Oh, you can't. You would just have to, if you want to answer questions now.
No, somebody else asked that, not me. Okay. So this is what happens basically. When one day it's something chronic that happens. It's something chronic that happens that it takes a long time. It's not something that happens suddenly. It's something that takes a lot of time. And it takes people maybe 10, 15, 20, 25 years, and it has to do with all the risk factors, age, which unfortunately we can't control, smoking, high blood pressure, diabetes, history in your family of peripheral arterial disease. Those are very important. And then hyperlipidemia with the high cholesterol, high triglyceride, all those things are risk factors. There's an important thing too that a lot of patients ask me is that patients say, I don't smoke anymore. Anybody that has smoked more than 100 cigarettes in their lifetime is at risk of having peripheral arterial disease, because once you smoke, what happens is there's injury to the artery, and in that place that there's an injury, it creates a piece of plaque, and once that plaque is created, it can just develop slowly, but it might take years. But even if you stop smoking 10, 15, 20 years ago, you still have the risk of having peripheral arterial disease. And then it's divided into different stages. Most patients that have peripheral arterial disease have absolutely no symptoms. And it comes with age, high blood pressure, and it might just be mild symptoms that they have. And then usually nothing happens to those patients. They live their life without issues. But once you have peripheral arterial disease, this is associated with heart disease, disease of the carotids that can cause stroke. So if we identify somebody early with peripheral arterial disease, then we can associate it and study their heart, their carotid arteries, because it's directly associated. The same thing that happens in the arteries of the leg happens in the arteries of the neck and in the heart. Then the next stage is called claudication, which means pain with walking. And it's usually, if you think about it, it's basically a little heart attack of the legs. So it only happens in muscles, and it only happens when you walk. It doesn't happen at rest. And then when you walk, you're walking and your blood flow, you require more blood flow because you're using your muscles. And when you have hardening of the arteries, there's a blockage that's not letting blood go into the muscles, and that's where it hurts. And then the last part, and it's the part that we treat the most, it's when it's causing such bad blood flow to your leg that it's threatening the leg, and you have a wound, you have pain all the time without walking, gangrene. And those patients, if we can get them earlier, we might be able to help them, and we prevent all the amputations that we unfortunately have to do. Okay, there's a couple of things that are very important, because a lot of patients come and they say, oh, I have pain with walking. There's multiple different types of pain with walking. Like I said, it's very important to differentiate blood vessel and blood flow issues when you walk, and there's other things that can cause pain with walking, and that can most likely be a nerve. So It's very specific blood flow issue. It's always when you walk, okay? And when you walk, it's usually the same distance. So every time I walk 4 blocks, my calf tend to hurt, or my buttocks, or the thighs, but it's a very similar distance. And then I have to stop. Once I stop, the pain gets better. And then when I walk again at 4 blocks, and again it hurts. Different from pain that is related to nerves, that usually pain that is related to nerve, it's associated with a certain position, being in a position for too long, and it can be better when you're like pushing your shopping cart at the mall. It gets better because it's basically a spine issue where the disc gets compressed, and when you're pushing the cart, you're increasing the angle of the spine, and it improves. The other thing that's important is there any shooting pain, any pain in your joints, or any pain in your back of your thigh. That's most likely due to nerve issues. Again, blood flow problems tend to be when you walk, and it tend to be only in muscle groups, either the calf or the thigh or the buttocks, but it's always when you're doing something active, because that's when you need more blood flow, and that's when it hurts. And then limb ischemia, which basically means critical decrease in blood flow. It's when you have either tissue loss, either with a wound or gangrene, or when you have pain at rest that's all the time, it's just unbearable, and it's always in the foot or the toes. These are the patients that are at significant risk of limb loss, of losing their legs, and even risk of heart attacks, and they can die of a lot of other things, because once your arteries are that bad that you have tissue loss, it means that the whole body is affected to a level that's very significant. So these patients tend to have overall bad prognosis once you have critical limb ischemia with a wound. And what happens in the wounds is, when you develop a wound, let's say you cut yourself in the toe, in about 2 weeks that wound should heal, unless you're, there's other factors. If you're steroids, you're going to heal less. Some diabetic patients might take a little bit longer. Certain medications that compromise your immunity take longer. Patients on chemotherapy. But if you're a normal patient with maybe blood pressure issues and history of smoking, and in a couple weeks that wound doesn't heal, that means that there's not enough blood flow to heal the wound. Once you cut yourself, you require more blood flow than usual to heal that wound. And when you have a blockage, there's no blood flow that can get there, so you don't heal the wound. So usually about 2 weeks is where, if the wound doesn't heal, there might be an issue, and you should definitely seek medical attention, either your primary care physician, and then they'll establish your blood flow to the foot. But that's very important. There's other wounds that happen more in like the calf area. Those wounds can be either mixed, meaning arterial or venous, but a lot of those wounds, especially if they're accompanied by swelling, have to do with venous disease. Arterial disease, which is what I'm talking about today, is most likely wounds in the toes, in the foot, or a wound in your ankle that never healed after you scraped it, things like that. They usually don't happen in the calf. There's about 8 to 12 million Americans, and this is probably underestimated, like I said, because a lot of people don't seek medical attention for different reasons until they're very, very advanced disease. And then we're seeing the steady incline because the baby boomers are now in their 60s, and the population in general is growing older, so we have more and more patients every day come. And unfortunately, a lot of them come in a stage that is too advanced to do anything. But as the years go by, we've been seeing a steady increase in the amount of peripheral arterial patients that we see in the hospital and the office. And this is basically what happens. First, you have an injury, and that can be due to high blood pressure, that can be due to smoking, that can be due to diabetes. The high glucose levels cause injury. And once that injury forms, the inflammatory process of the body attacks that area, creates inflammation, and you form this plaque. And this plaque is made out of inflammatory cells, and it's made out of cholesterol. That's why high cholesterol, high triglycerides, and then unhealthy diet also is associated with peripheral arterial disease. It keeps accumulating until one day it clots off, or it's severely narrow that it doesn't allow the blood flow to go to the foot. The arteries are, when you're born, arteries are very nice and soft. As you age, no matter what you do, even if you're the healthiest person, you'll have somewhat of a little bit of increase in the thickness and how soft they are. But the smoking, the high blood pressure, or the uncontrolled diabetes, all those risk factors worsen this, and they basically become like a bone. They become very calcified on these patients, and it, that's why they clot off. And then again, just to mention, the most important risk factor, all of this is smoking. So smoking is the most important factor, and it's the most preventable. You know, none of us really need smoking, so just stopping smoking can decrease the risk of everything. It can decrease the risk of peripheral arterial disease, but it can also decrease the risk of cancer, coronary or heart disease, stroke. Just stopping smoking can decrease the risk of a lot of things. The other thing is diabetes is the other worst one, especially uncontrolled diabetes. Just having diabetes, if it's well controlled, and your hemoglobin A1C, that number that they do every 3 to 6 months, is less than 7, those patients fare pretty well and they don't have issues long term. Once you have diabetes that is severe and it's uncontrolled, those are the patients that do poorly, because those patients have accelerated issues through their arteries. Hypertension is very important. Dyslipidemia means high cholesterol, triglycerides. Being male, tend to have more than females. And then kidney disease. Kidney disease is a horrible disease that where patients require replacement therapy through a machine, and those patients have hardening of the arteries from a different pathology. But a combination of some of these patients is high blood pressure and diabetes is a very common combination. That combination can be lethal. And then age, unfortunately, we can't really control. So how do we screen these patients? It's very easy. It's very non-invasive. No need for any needles. And what we do is we basically compare the blood pressure with a little ultrasound, and we make this index. It's called the Ankle-Brachial Index, and basically comparing the blood pressure in your arms to the blood pressure in your ankles. You got two arteries in the foot that we compare to the artery in your arm. And what that does, the artery in your leg should be about 0.9 to 1.2 the blood pressure in the arms. And if it's less than that, you might have just mild disease, which is 0.8 to 0.9. You can have moderate disease, which is 0.5, and then less than 0.5, it's considered to be critical, and that means that there's an issue with the blood flows not getting to the leg. And it is very simple. It takes about 20-30 minutes at the most. There's no needles involved, and it gives us a lot of information, and we can compare upper extremities to lower extremities, and then it's a very simple, quick way to screen patients. And once you have, especially if you're above 65, once you have one ankle brachial index that's normal, it's very unlikely that this progress rapidly, so it will take years and years and years to develop. So once you have a normal ankle-brachial index, that basically tells you 5 years you're pretty good. You shouldn't have any issues unless you suddenly decide to pick up smoking, which could accelerate everything. But if you keep your medication and your medical problems under control in a normal ABI, you won't have any issues in the future, especially if you're a patient above the age of 60, 65. So this is how we start with the patients. And then if we find something that's abnormal, it all depends on the symptoms of the patient, not because you have an abnormal ABI, because the number came back and it was low. That necessarily means that we have to do something, you need surgery or anything like that. It's all about the symptoms that you have. So it's very important to understand that if you don't have any symptoms, you don't have pain when you walk, you don't have any issues, no wounds, you get a little cut in your toes and it heals well. Even though you have a slightly decreased number, that doesn't mean that you necessarily need a surgery and an intervention. And I see this fairly common when the patient presented to a different place and they had a decreased ankle-brachial index, and they did surgery on the patient. The patient had absolutely no symptoms at all. It was just an incidental finding that they found on a screening test. It's important that it has to be associated with some kind of issue with the patient. So if you don't have any symptoms, there's no reason to do anything. But like I said, what happens is there's an injury to the artery, then the plaque gets built up there, and then what happens is at some point it clots up completely, and that's usually when it starts to give you problems. There's a couple things. People that have smoking, they're typical smokers, they tend to have more of a pelvis area disease, so it's all in the aorta, we call it, and the iliac arteries. Those patients that smoke tend to have more likely pain in their thighs and pain in their buttocks. The patients that are diabetic tend to have more likely disease in the thighs and below the knees. So those patients that have diabetes can present with pain in their calves, or most likely they present with wounds or pain in the foot. But the smokers tend to have more of a abdomen and pelvis disease. So it kind of differentiates a little bit depending on the pathophysiology. And like I said, most patients are completely asymptomatic, even when they have a drop in that number, the ankle-brachial index. They don't have any issues. And those patients that have no symptoms, they can live long lives without any issues. But again, once we find that you have peripheral arterial disease, it's kind of a marker to tell us that, okay, this patient could have disease in their neck that can cause a stroke. They could have disease in their heart that can cause a heart attack. So it's actually a good marker if you're found to have peripheral arterial disease to look into other things that can be also an issue in the future. And then you got the patients that come with claudication, which is the pain with walking. Those patients tend to do pretty well. When we get those patients early, they usually do really well. And most of the patients, you can just do an exercise program when the patient just walks, and they get better. Some patients require intervention, and those patients typically do not progress to critical limb ischemia that requires amputation. Most of these patients don't have issues in the future, and it's about 1% a year of having a major amputation, so it's very low. It's more about having issues with your activities of daily living, being able to walk, being able to be active. That's when the patients come, because they're not able to do what they used to do in the past. And then critical limb ischemia, like we talked about earlier, unfortunately, a lot of these patients do pretty poorly. And it's because most of them seek medical therapy very late. and they progress very rapidly. Once you have critical limb ischemia or like tissue loss, a lot of these patients are not even alive at a year, because that means that their whole body has the same problem and they have gangrene or tissue loss. A lot of these patients end up with the amputations. So it all depends on how bad is the wound and where is the disease located and how bad is your number, the number that we talked about. If it's less than 0.5, that is a bad number, and it's associated with major amputations. They also have other risk of having a stroke, heart attack, all these things. Prevention is the most important thing. Like we said, we need to get the patients in early so we don't get to a point where they require an amputation. Again, prevention is okay. And how do we treat these patients? Most of these patients, what we do, first we do medication. Okay, we diet, improve diet, control your diabetes, control your blood pressure, stop smoking. And patients, if they have cholesterol, we start a statin, which is very important for anybody that has peripheral arterial disease, should be on a statin no matter which one. But usually there's two that we use the most amount of time, and they need to control the diabetes with the hemoglobin A1C less than 7. And then we put them on aspirin. So everybody that has peripheral arterial disease should be on a baby aspirin. It has very low risk and complication and a lot of benefits for the heart, for the legs, for strokes. And then some patients we add another medication. Most patients just with aspirin, they're okay. And then, like I said, you gotta be aggressive about controlling the diabetes. You gotta control the blood pressure, and it has to be a goal less than 140, and then you have to stop smoking. And then there's way we can help you with smoking cessation. There's patches, there's gum, there's medication, but smoking cessation is probably the most important way to prevent this from getting to a point that we can't do anything about it. Here are some of the things that we use. We use medication, we use nicotine patch, we use gum. Some people ones work, some others work. Some people just quit cold turkey. It's up to them. And then the first thing that we do is not necessarily surgery. The first thing that we do with every patient that comes with pain when they walk, when they don't have a wound, is to walk. And what happens is when you walk, you increase the body is pretty smart and says, okay, we need to get blood flow to the calves, or we need to get blood flow to the thigh. So how do we do it? This place is blocked. We need to go around it, and it creates alternative pathways to that area. And it also, what it does is it kind of like teaches your muscle that it's okay to walk with a little bit of pain. And then a lot of these patients can walk more and more and more. And then we do 3 months of exercise, and then they can walk 10 blocks instead of 5. Then we keep going, and they can at some point walk normal without issues. So this helps about 50% of the patients that come with the claudication. And of course, it decreases other things from happening, cardiovascular events, strokes, all those things. There's one medication that we sometimes use with the patient. There's cilostazol is the one that I use always. It's been proven to be pretty good at improving the distance that you walk so by 50%. So every couple months you'll be able to walk more. Pentoxifylline, we don't use it anymore, but definitely use cilostazol, and a lot of patients tend to have good results. The problem is you can't use it with any patient with heart failure. And then after that, we decide if none of this works, or is affecting your lifestyle, and you can't do the things that you used to be able to do, then we talk about doing interventions. That's the only time when your symptoms are really severe and you can't really live your life. That's when we start with treatment. And everybody starts with the same treatment basically, even if you have critical limb ischemia with a wound or you have claudication. Almost everybody starts with the same procedure, which is an angiogram or arteriogram, where we go in the artery and actually take pictures. And then the good thing about these pictures is that at the same time, not only can we take pictures and make a diagnosis, but we can also treat. And when we treat, we can do multiple things. We can use a device that shaves and removes the plaque. We can use a balloon or a stent. We can do multiple things to improve the blood flow. And the technology keeps getting better and better when we can treat more and more people. Back in the day, we could only treat a small amount of patients. Now we can treat a lot of patients with minimal invasive procedures, where we clean up the plaque and the patient goes home after the procedure, after staying flat for a couple hours, and they don't have to come to the hospital and stay in the hospital like back in the day when patients needed bypasses and bigger surgeries to treat the same disease. So now everybody gets started with an angiogram, and we try to clean everything at the same time and send the patient home with medication. Usually when they have to undergo an intervention and it's a successful intervention, then we add medication for a couple months. So this is basically it. We basically go into the artery and we take some pictures. You know, these are the pictures. And as you can see, there's kind of like a stop here. There's an artery here. There's another artery on each side. And right in the middle, there should be an artery here. And that artery is called the superficial femoral. This is probably the most common artery that I fix. And it's right in the thigh, in the middle part of the thigh. And that artery, we can clean it out, put a balloon, a stent, and then improve the blood flow to the foot. This is one of the things that we do. This is the device that we use to clean. We can use balloon stent, multiple things. We got a lot of toys to play with. This is another example where you can see here in the middle, this artery severely diseased. There's no blood flow, and then after you open it up, there's increased blood flow, and then the symptoms are gone. And the symptoms are immediate. Like as soon as you can walk the day after, you will not have any symptoms. The good thing is it's minimal invasive. It's usually very comfortable. It's an outpatient and faster recovery. The problem is that a lot of these patients have recurrence, especially if you keep smoking. So that's very key. If patients continue to smoke, don't control the diabetes, high blood pressure, then they tend to come back. Most patients do really well if they control the diabetes and they their high blood pressure and stop smoking. There's risks with everything, of course. You know, you can try to fix the arteries, make them bleed, but they're very low risk. And the technology that we have is so good that we have less and less complications. And then there's surgery. Surgery is way more involved. It requires multiple incisions, and it usually either requires us to clean the artery, take all that out, or a bypass surgery where we go from one artery that has blood flow to another one that has blood flow around the blockage. And that would require an admission to the hospital and staying in the hospital a couple days. And then there's a little bit of a more painful post-operative period for sure. The good thing about these surgeries is because you're actually removing the plaque and doing an actual bypass, these tend to last longer. And depending what you do, especially if you have to do surgery on the bigger arteries, those can last years and years. The problem is you have general anesthesia, which can affect your heart. And then one of the most common risk factors and the things that happens is actually having a heart attack, but it has to do a lot with the anesthesia plus the procedure. There's also bleeding because you're actually cleaning the artery, so they're more likely to bleed. There's multiple trials that are trying to decipher what's better for the patient. Is it better to do endovascular minimally invasive or is it better to just do surgery? Unfortunately, none of these trials have been able to tell us, okay, this is definitely better than the other. So it's kind of each physician to decide what to do with each patient, and be at that point you have to basically treat every patient specifically. Unfortunately, there's no data that has been published that says, okay, this is better, everybody should be treated like this, or the other one is better, so we have to kind of make our judgment. But most patients, I think, prefer to go minimally invasive first. And then if that doesn't work, then we go with surgery. But a lot of patients never require any intervention if you get them early. And then, like I said, the most important thing is prevention, risk factor modification, high blood pressure, smoking, cholesterol, diabetes, baby aspirin, and a statin, and then activity. Walking all the time as much as you can, and then if you have any pain with walking or you develop wounds that don't heal, talk to your doctor. But that's the most important thing is probably prevention. And that's it.
A few questions in the chat.
Okay, so we got some questions. What am I using? Yeah, so we talked about angiogram already. Yeah, so the angiogram is what we talked about when we go in and then we clean the artery with either a balloon or a stent or what I call a roto-rooter. We just clean the plaque and take it out. Fortunately, more and more technology comes out, and it's very good, and I can do some very cool things to get the plaque out, and it lasts longer. The more we do these days, the longer it is, and we do a lot of these, probably half a dozen a week, probably. But yeah, that would be always my first. Deep tissue thrombosis. Deep tissue thrombosis can happen for different reasons. What happens with deep tissue thrombosis, this can happen either for vein problems, it can happen even from medications, and it can happen due to arterial disease. What happens is when you have very poor blood flow, or even in diabetes, the arteries get really, really diseased, the small vessels, or when you don't have blood flow, the little capillaries and arteries kind of die, and then they clot off, and that's how you start wounds. Usually you have is because there's this clot in the little skin and the little arteries, or because of when you have diabetes, the arteries are very diseased and they clot off, or because of the high glucose levels. It's a very ABIs is a very easy thing to ask from your primary care physician, but some patients, before getting an ABI, it's very easy to palpate their pulses. So if a patient comes to the doctor and they ask for ABI, but the doctor can easily feel their pulses, so you look for those in the foot, which you can usually feel very safely. So that if you can feel pulses with your bare hands, that means that you have enough blood flow that you should be able to heal anything. If there's a problem with wound healing, then I would get ABIs. But yeah, if you can't really feel pulses, if the doctor can't feel pulses, an ABI is very easy. And being proactive about it, it's a great idea. Never smoked cigarettes, but did smoke one cigar a week for about 15 years. It definitely has increased risk. You know, the difference that people think from the cigar and the cigarettes is that inhaling, and a lot of patients say that to me, but you still absorb a lot of nicotine through your mucosa, so you still cause injury to the arteries. So every time you smoke the cigar, that causes injury to the arteries, and then nobody has come up with a number. Now, you know, cigarettes, they come up with 100 cigarettes. What is the equivalent of cigars and cigarettes? I don't really know, but definitely smoking cigars frequently, chewing tobacco, all of that, you absorb the nicotine, and that's what puts you on risk.
Exit. Any more questions?
Any more questions? How many years? So I did it the shorter way, which is 2 years. It took me 14 years. Yeah, 14 years. But I did it shorter. Some people take 15 and 16 years. What's the difference between an artery and a vein? So the arteries are the most important. The arteries take blood from the heart to the tissue, and you can lose limbs, organs, everything. The veins, what they do is bring from the tissue and the organs, they take the blood out and go to the right side of the heart. They just present very differently. The arteries are usually chronic thing that takes forever. It takes a long time, and it has specific risk factors, which are we already talked about. Venous disease of the legs has to do more with genetic predisposition, family members having it, having a history of working in a place that you were standing up a lot of times. And what happened with veins, so the veins specifically of the legs, is when you're born, you have these little valves in your veins, and they're supposed to open and close. And they're supposed to close, and the blood is only supposed to go up to your heart. But when you've been working for long hours for multiple years, standing up, obesity, smoking, inactivity, and genetic factors, these valves leak and they stay open. And what happens is the blood flow goes up and down, and then what you get is swelling. So it's a different type of symptom. Venous disease causes swelling, causes aching, kind of different discomfort, and it has nothing to do with walking. Venous disease improves when you walk more. Arterial disease, when you walk, it's when it hurts. The venous disease improves when you walk because the muscles compress the vein and move the blood flow up to the heart. Okay, does sitting for a long period of time cause a problem? That can cause other types of problems. But yeah, the more active you are, the better it is. There's a lot of techniques when you're sitting for a prolonged period of time. Just moving your ankles, that basically what it does is compresses the muscles of the calf, and that moves your the blood flow up. But yeah, anything that you do for a prolonged period of time is good. It's bad. There's nothing in excess is good. Sitting for a long period of time, standing for a long period of time. If you're sitting for too long, you can have your blood flow is not moving. So it's bad from the venous standpoint. It does not affect the arteries, sitting for a long period of time. Effects of flying and DVT. Okay, so that's when you're flying, there's a couple. Does veins get clogged with cholesterol? No. Veins do not get clogged with cholesterol, only arteries. They have a different mechanism. Veins are very thin, and they don't get injured the same way. Veins get clogged. And what happens when you fly is that you're in the same position for a prolonged period of time, and against gravity, the blood flow doesn't go up. So just moving, like I said, your ankles, that basically moves the calf muscle, stretching and moving your knees also moves all that blood flow. But when you're flying, you're in the same position for a prolonged period of time, and the blood in the vein, it's called stasis, where the blood in the vein stays in the same place instead of going up. And when it stays in the same place, it clogs up, and then you can get a DVT or a deep venous thrombosis. That's what happens. And it doesn't even have to be flying. It can be driving for a prolonged period of time. Everything above 2 or 3 hours, you should at least get up once or move your legs so you get all that blood flow up, or just wear compression stockings where it moves the blood flow. Anything else?